Hello guys, hello family, hello friends. This is Dr. T and welcome to Clinical Medicine with Dr. T. In this video, we're just gonna be probably talking about bundle branch block. Bundle branch block. You know guys, they also call it BBB. You know guys, I'm gonna sound somehow in this video, or what I'm gonna say might not really sit well with some people, but I'm gonna say it. You know, many doctors, I'm talking about senior doctors, I'm talking about medical officers, I'm talking about comserves, interns. Many doctors do not want to do ECGs. And the reason why they don't want to do an ECG, for them, it's, for everyone, an ECG is not a comfortable zone. It's not a comfortable thing that you want to be thrown at and then have to interpret it. It's not easy. It's one of those things that just makes people to be very shaky and feel uncomfortable. That I understand. Even myself, I'm like that. But that should not be the reason why we don't do ECGs. It's the rate at which we do ECGs is so low, and we are missing things. Like in the past 2 weeks, when I started doing OPD, in just 2 weeks, I picked up about 5 conduction abnormalities, and I had to discuss those patients with a cardiologist for an echo. And if I can pick up about 5 in 2 weeks, if I was not in OPD, who would have actually picked these abnormalities from these patients? Because I know in my hospital, even in my hospital, people do not do ECGs. And it's not only here. Even when I was an intern, there are senior doctors who don't even know how to look at an ECG. They don't even know where to start. It's even worse when it comes to surgical disciplines. Internal medicine, family medicine, those people, they do actually look at ECGs and all of that. But other disciplines, it's also anesthesia that really takes ECGs serious. But people from ortho, all the surgical disciplines, it's so shocking. The thing is, if you don't, an ECG is just like a chest x-ray. It's so easy for us to order a chest x-ray, like we order a chest x-ray carelessly. It should be the same with an ECG. We should order an ECG carelessly. It shouldn't be like a thing that now, okay, I'm gonna do an ECG, or I have to do an ECG. No. It should be just like that. It should be so simple to do an ECG. Personally, I started doing ECGs when I didn't know how to interpret an ECG, but what I focused on is placing the leads correctly, because I knew that I'm always going to find someone who can help me interpret the ECG. So as long as you have someone, you can even send a WhatsApp. You can even send an email to someone, a WhatsApp, call them, and show them the ECG, and they will help you. So you don't have to be reluctant doing ECG just because you know that you can't interpret it. Because at the end of the day, patients are not getting the best that they should be getting. I know people who are in surgical disciplines are like, I'm going to be a surgeon, I'm going to be this, I don't have to. No, you are a doctor. You know how to look at it. When a psychiatrist, let's say they struggle to read a chest x-ray, then the surgeon should not be laughing at the psychiatrist and say, I don't even know how to check it, to look at a chest x-ray. Because you also don't know how to interpret an ECG. So we should just, guys, I'm begging you, let's start doing ECGs. Let's start doing ECGs. And also, as junior doctors, you must know that you're gonna do ECGs everywhere. You will do an ECG for a pre-op patient in surgery. You will do an ECG for a pre-op patient in orthopedics. In anesthesia, you are gonna do ECGs. In internal medicine and family medicine, you have to do ECGs there because those are medical patients who have got risk factors for cardiac abnormalities and that kind of a thing. So there's just no way of running away from an ECG, not unless, I don't know. And also, as a surgeon, doesn't matter the actual discipline, but as a surgeon, when the anesthetist is counseling your patient and saying we cannot be operating this patient because of ECG changes that are abnormal, you should understand exactly what they're talking about. And by the way, you're supposed to have picked that up and then consult them and be like, okay, I've got this patient that is due for operation and I've just picked up, they've got this. What's your take? You shouldn't be the one, you shouldn't be hearing from the anesthetist for the first time that actually your ECG is abnormal. I find that embarrassing. Anyway, okay. So guys, let's talk about BBB, bundle branch block. So let's quickly just revisit the basic anatomy and physiology. So this is our SA node, our AV node, our His bundle. This is our left bundle, our right bundle. And what is important is that we all know that this is the SA node. Forgive my node there. Node. And the reasons of doing an ECG, they are not obvious. You will never do an ECG if you are waiting for obvious signs and symptoms from the patient. Personally, a patient with palpitations, I do an ECG. This is how, that's my criteria. Palpitations for me is equals to an ECG. And then when you take history, you find that they get dizziness, they get syncope, those other symptoms. But palpitations for me is equals to an ECG. And that's how I've managed. And I actually want to improve. I want to do more ECGs actually. I want to do more ECGs. So this is the SA node, this is the AV node. Let's just be consistent there. This is the AV node. And this is the His bundle. Or bundle of His. And this is your right bundle branch. This is your left bundle branch. Let me just remove this and not talk about the fascicles. We are going to talk about the fascicles in another video where we talk about fascicular blocks and all of that. Let's just keep it simple for now. Okay, and we also know that this is our conduction system. So this is the Bachmann's branch, internodal pathways. Internodal pathways, they actually allow the movement of or transmission to the AV node from the SA node, right? So now, when you talk about bundle branch block, what we know is that the electric current or etching potentials are generated from the SA node and they spread out via the branches that I mentioned and get to the AV node. When they get to the AV node, they're actually delayed for a few milliseconds to allow complete atrial contraction, so that by the time ventricular depolarization and contraction begins, the atrium or the atria, they're done with contracting. If this is a very important concept, if action potentials and that wave of depolarization is moving down here, and as soon as it gets here, it propagates downwards. It means that by the time the ventricles are depolarizing and contracting, the atria is still contracting as well. So you can't have that chaos. When you've got atrial contraction, you should have ventricular relaxation and vice versa. So that delay by the AV node is exactly to allow the atria to completely contract while the ventricles are still in diastole. So there's that delay there. So as long as we are still waiting for action potential, for depolarization of our nodal cells, we're going to have a flat line. But then as soon as depolarization occurs, then we get that positive deflection, which is smooth and semi-round or semicircular, whatever, called the P wave. And then as propagation occurs, AV and the bundle phase, they receive the action potentials. When now you get to the ventricles, you're gonna get that dip. Maybe let me just use this. So you get that QRS. The Q is a negative deflection, very important. The Q wave is a negative deflection. There is no Q wave that is positive. It's a negative. Once it's positive, once after the PR interval, you get a positive deflection. That's not a Q wave. So a Q has to be negative. Then from a Q you get your R and you get your S, and then like that. And you go back. And then you are back to your isoelectric line, and then you get your T wave. If you Google a normal ECG, these are the drawings that you're gonna be seeing. So what we wanna focus on when I talk about a branch block is this section here. So this part is our QRS complex. This is our QRS complex. Now, what is this thing about bundle branch block and all of that? So what happens is that in a normal heart, you know that from here to here, which is your PR interval, you are supposed to have about 3 to 5 small boxes, right? We're not going to talk about the PR interval or the P waves in this video, but I'm just mentioning it here. Then from Q to S, you should have less than 3 small boxes. Small boxes, right? And if you remember, one big box is something like this. One, two, three, four, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4. So we need an extra here. So the big box has got about 25 small boxes. This is 5. 1, 2, 3, 4, 5. 1, 2, 3, 4. 5 and 5 is 25. So it's about 25 small boxes. But that number is not important. The important number that you guys must remember is the number of small boxes on the side or on the horizontal plane from here to here. That's what is important. So this small box is about 0.04 seconds. This small box. And the QRS which we're talking about now, a normal one should be less than 3 small boxes. Less than 3 small boxes. It's actually very easy to count the number of small boxes, especially if your machine is actually printing nicely. It's actually very easy. You can actually count them. One mistake that you guys must try and avoid is the QRS complex. That's the QRS complex. The QRS complex when you count, don't count from the beginning of the R wave. Count from here, beginning of the Q wave, and end at the end of the S wave, which is here. So try and trace your isoelectric line. As long as it remains flat, you're not going to start counting. But the minute you get a deflection, whether it's upward or downward, that's when you start to count. So don't, because some people I've seen, they'll try to count the boxes that are here. That's not complete. So a complete QRS complex starts from the Q. This is where the Q begins, this is where the S begins. So you count across here, those small boxes, right? Okay. I'm tired of using my hands to wipe. I'll just use this. So this is what we know. We know that a normal QRS complex should be less than 3 small boxes. But what does that mean in terms of numbers? So in terms of seconds and milliseconds, if one small box is 0.04 and we say that there must be less than 3 for it to be normal, for the QRS to be normal, then we can simply say 0.04 multiplied by 3 will give us 0.12 seconds. So which means the QRS should be less than 0.12 seconds. And an easy way of converting seconds to milliseconds, you just multiply, you just move that arrow 3 times. So if you move it 1, 2, 3, old school mathematics, that's going to be 120 milliseconds. Right? So you want your QRS complex to be less than 3 small boxes. You want it to be less than 0.12 seconds. And you want it to be less than 120 milliseconds. So if you, whatever number of small boxes you get, if you multiply that by 0.04, you will get your milliseconds, and then you will get your, in case they ask this on the exams, they give you 5 small boxes, they ask you what are the milliseconds there, you just multiply that by 0.04 multiplied by 5, then you get whatever that you get. So those are the 3 numbers that must be in your head, all the time. Very important numbers. Because especially for exam purposes, you might find that you only know that a QRS should be less than 120 milliseconds. But now they tell you about boxes or they tell you about seconds. What are you going to do? So you should be able to move from one to the other. Like even if they can tell you that this patient's QRS complex is about 116 milliseconds. Then they ask you how many small boxes is that, or how many seconds is that. You'll be able to navigate from there to the other using the method that I've just shown you now. Okay. Now that we have that, just gonna rewrite this nicely. So the big numbers that we must know, 3 small boxes. 0.12 seconds, 120 milliseconds. Those are the big numbers that we have to memorize for this session. Okay, now coming back to the conduction. So we know that normally our conduction should take 120 milliseconds, or should take less than 3 small boxes in a normal patient. But now as electricity comes, action potentials, they move down. Once they start here, they start to, from the bifurcation into the right and the left bundle branch. Now, the things that can actually make the QRS to be prolonged is when there is a partial block or there's a complete block. So the longer it takes for action potentials to move down the ventricles, the longer it takes for them to actually move down the two branches, the longer it takes, the more wide will this be. Because, for instance, if we say 120 milliseconds is from here to here, now if the conduction is taking longer, then it means it's going to now be from here to here, or from here to here. So the longer it takes for the current to travel in the branches, that will increase the number of boxes, and that automatically will increase the number of seconds, and that will automatically increase the number of milliseconds on the ECG. That's how we pick it up, that the conduction is not moving the way we are used to. We know that it should take 3 small boxes for the entire depolarization of the ventricles. But now we've got 4 boxes, now we've got 5 boxes, now we've got 0.16 seconds or 160 milliseconds. What is actually happening? So it means the movement of action potentials is not normal there. And how are you going to see that on an X-ray? Even before you count, you're going to get what they call broadened QRS complexes. So your QRS will be broad. Now, your QRS will move from this to something like this. I'm just exaggerating it here. So now, all of a sudden now, when you look at this, you can just see that no man, these QRS are wide. I've not counted, but I can just see they are wide. There are those that are just obvious. But then there are those that will actually need to count. But you're gonna count on all of them anyway. This one you can see now, man. There's like gross morphological changes on this QRS. But let me just count. Then when you count, you find that this is my first small box, this is my second, this is my third, this is my fourth, this is my fifth. So this patient that we have here has got 5 small boxes. And if you want to translate that into seconds, you just want to say 0.04 multiply by 5. And then, so now you can see that if you've got 5 boxes, theoretically you know that they're supposed to be less than 3. So your suspicion based on the morphology, on how it looks initially, it has been proven to be correct, because you've got 5 small boxes instead of 3 small boxes. So we've got a confirmed broad QRS complex. At this point, what you know is that you have got a BBB. So what you know at this point is that you've got a BBB. And at our level, this is enough. You can actually send this patient, discuss this patient, check if they are hemodynamically stable or what is happening. see if you need to resuscitate before you send the patient, but you need to discuss this patient. So, as a junior doctor, picking up a BBB is actually enough. Whether it's the right or the left, it's not important for us. It's going to be important in the future, but also saying deciding if it's a right or a left BBB is not difficult. I'm just going to show you how to pick a right bundle branch block now. But at this point, we know that we've got a BBB. We don't know the cause, but we know that we've got a BBB. Now that we know that we've got a BBB, how do you know if it's left or right? We're talking about right here. I'm gonna give you guys. I'm not gonna explain to you because these are the things that I also need to actually go sit down and really grasp and understand. I'm gonna give you now an explanation of why the morphology is like this, why is it not like this, blah 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 blah, why you've got so I'm not gonna get into the details, but I just want you guys to be able to pick it, because for me this is working and I've actually managed to pick up a lot of patients. Like the ECG I'm gonna show you at the end of this video is a patient that I saw last week or last week. So you'll see how the ECG is. So with this basic information, you can still pick up bundle branch blocks. Okay. Now, to decide if you've got a left or a right branch block, you must look at V1 and V6. There's this thing that helps people to, there's this name that helps people to remember. It's called Moro. It's called Moro. M for Moro, and then the R there is for right, and then this is for W. This is W, Moro. So what this is telling us is that on V1, when you have a right bundle branch block, you get an M-shaped QRS. And on V6, you get a double-shaped QRS. Right? So, this is how it's going to look. You're going to have your P wave, your PR, and then now, instead of having a downward deflection, you get something like this. You get an R, and then it comes down, and then it goes up again. That's the M that they talk about there. I want you guys to actually Google and look at how the M's look like. Also call it the bunny ears, just before I forget that. The bunny ears. Rabbit's ears. So if you can put a mouth here, put eyes here, maybe this is how a bunny will look like. I don't know. But they call it the bunny ears. This is a right bundle branch block. On V1, that's how it looks. That's how it looks. So, on V6, you get something like this. Instead of it going up now, it just dips like that. So that's the W of Moro. So if you've got this kind of morphologies on V1 and V6, that's why I was saying I'm not going to start to explain now why you have those changes on V1 and V6 in particular. I mean, it's things that I need to sit down and also grasp. I've got an idea, but I need to sit down and grasp those things. But I'm just trying to be basic here and just help my fellow junior doctors on interpreting ECG. Right? So that's So the important thing here that you guys must remember: look at the morphology of the QRS, have your suspicions, count the number of boxes, diagnose your BBB. Now, to differentiate if it's left or right, check V1 and V2. Check if you see on V1 you see an M, and on V6 you see a W-shaped QRS. Then you can refer that patient saying, I think this is a right bundle branch block, right? Now, what if it's a left bundle branch block? You still look at V1 and V6, but the way of remembering the left, just remember William. Once again, in V1, you've got a W shape. In V6, you've got an M shape in V6, if it's a left bundle branch block. So now, if it's a left on V1, this says that on V1, you're gonna get a W. I'm gonna show you guys here. I'm gonna show you something that's actually very funny. So that would be the left, and then now when you go to V6, that's where you find the M. On V6, that's where you find the M. Okay, doesn't really come down all the way, but yeah. So the green is left bundle branch block. The blue is right bundle branch block. So the reason why I was laughing when I was just drawing the W is because there are some funny W morphologies that look like this. They'll be like these, and then there's just a small notch there. Then it goes up, and then it does that. So this is a simple way, guys, of diagnosing. It's not very difficult. It's not very difficult. Like, just to recap, we're saying that the first thing that you must be able to identify, check the morphology of your QRS. There are some broad QRS morphologies, like the morphology just looks abnormal even before you can count the small boxes. But okay, fine, you count the small boxes, you find that the boxes are more than 3. You have a BBB. Now, to decide if it's the left or the right, go to V1 and V6. If it's a right bundle branch block, V1, you're gonna get an M shape, V6, a W shape. If it's left bundle branch block, V1, W shape, M, and then you get an M in V6, right? Then you're done. You're done. So you're gonna go through that. We're gonna go through that ECG now and see. I hope I'm not missing anything. So thank you so much, guys.